Then comes the most important topic of general surgery. These are the main topics why we are doing general surgery. Mechanical, the obstruction part, the small bowel obstruction and the large bowel obstruction. If you have less time and you don't want to do anything from general surgery, I would say just do this obstruction at least, at the very least. Okay. And then comes the obstruction, so you can forget about pathophysiology, common causes. You can read the common causes, just keep that in the mind so you can make the differential diagnosis. Okay. Then comes to the risk factors. Risk factors are important because on the basis of risk factors, sometimes it helps with the diagnosis as well. So, what could be the complication or risk factors that can cause the obstruction? Any previous surgeries, especially in small bowel obstruction. So the risk factors for small one and the large one is different. So any previous surgery, any abdominal mass, any previous history or risk of cancer, any prior radiations, IBD, or any foreign body ingestion. Then what could be the features, like how they are going to present you in the scenario? So what is the main thing? Colicky pain, nausea, vomiting, obstipation, delayed passage. There is no flatus, means very important, no flatus pass, and inability to tolerate any oral diet. So he's having nausea and vomiting over and over again, along with flatus pass. And then you did the examination and you find there is no bowel sounds and then you find abdominal distension. This can help you to make the diagnosis, especially in the daily life. But in exam, they like to make it tricky. So more frequent vomiters, vomiting is one of the important thing, especially in up small bowel obstruction. Passage of the gas or stool gas or stool that continues like 6 to 12 hours ago, or onset of the symptoms that is basically starting from 6 to 12 hours ago. Inability to pass flatus is the most useful indicator. So they will say these things in the scenario. If they are asking you to write on the diagnosis of small bowel obstruction, they will 100% say that there is no pass of flatus in their scenario. Uh, just one thing in your mind, when it comes to MCCQA exam, they don't make things complicated like UWord or like how the USMLE exams are. They make things very easy and very straightforward. We just try to think of tricky and all the time make things complicated. So that's why we try to assume this could be the thing, this could be the thing. So just don't assume whatever is written, it's there. Signs is basically abdominal distension, hyperactive proceeding of the minimal bowel sounds, then the blotting, hypovolemia, hyperresonance, then basically the strangulation obstruction is basically more pain, tachycardia, there is like, infection signs, fever, leukocytosis, and all those, and lactic acidosis, many, many important. So then comes to the investigations. So they can ask you in a small bowel obstruction, a case of intestinal ischemia or strangulated obstruction. Why? By asking you how you will rule out the complication of that one. So you have to do check for the lactic acidosis to confirm the diagnosis of that one. Okay. So you have to think if they have given you a scenario. Sometimes they don't just ask you for the diagnosis, they do like to ask you for the complication too. So, in that complication, not just the complication, what is the main test to do to rule out the complication? I hope I'm not making things difficult, but let's suppose if they give you a scenario about abdominal obstruction, you are able to make the diagnosis. Now they gave you a further thing like tachycardia, fever, and you reach to a level where you've already decided, yeah, this is basically a further lying infection or obstruction is or strangulated obstruction or ischemia is going on. Now, what they like to do is make a investigation for this case, like a case on the top of another case, and then doing an investigation. Okay. So important to know if chronic or is acute. So chronic distension is most likely to be tolerated without perforation. So it's pain, 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 and then it's going on for too long. Patient with no abdominal surgery history, patients with small bowel obstruction should have surgery as soon as possible. So how are you going to approach that case? Basically, because you are an emergency physician and a small bowel obstruction is very, very common. So you don't have to think of yourself as a surgeon here. You have to think of an emergency. So you are going to start with triaging. So you are going to think it's a mechanical obstruction from ileus, determine likely and easily etiology of the obstruction, differential complicated obstruction. It is basically a point where we have to start the calling the surgeon, or is it my level that I can start doing some investigations and wait for the surgeon? So now you are going to do the triaging. Now in imaging, so basically doing the X-ray, abdominal X-ray. You don't need to know the X-rays like how you supine X-rays or laying X-rays or lateral X-ray. You don't need to know that. Just an X-ray, abdominal X-ray, which is basically three views, triad of the dilated small bowel, air fluid levels, and paucity of the air in the colon. So in the colon there is air, then air fluid levels. So you have to see the X-ray. It's very, very important in QE1 and NACOSCI. You have to see the X-ray of abdominal obstruction. How does it look? Okay. So then CT with IV contrast. Usually with X-ray, it's enough, but here we do X-ray, sorry, CT scan to confirm the diagnosis. With IV contrast to confirm, and then discrete transition with a proximal bowel dilation, distal bowel decompression, and then intramural contrast does not pass the transition zone, so you can find out what's going on here. Most important to rule out the ischemic bowel strangulation, pneumalosis, intestinosis, so just see the picture. Then other is basically GI series and CT scan, so you don't have to go into very detail of that one. Usually we stuck with abdominal X-ray, CT scan. Laboratory, what are the tests that you are going to do? Maybe normal early in the cases. So you have to do the CBC, electrolytes, BG1, creatinine. Very important is lactate. Why you are going to rule out if there is an strangulated obstruction or any ischemia going on, intestinal ischemia going on, because it can cause lactic acidosis. Then creatinine, hematocrit to read out the degree of dehydration. So have the fluid and electrolyte abnormalities and metabolic alkalosis. So you need to know what kind of metabolic alkalosis will like the picture presents like ABGs, okay, presents due to frequent emesis. If strangulation, leukocytosis in the left shift, and then lactate as well, okay. Although lactate is a late stage thing, but usually by the time they present to us, that if this is going on for something too long, then you can always go for lactate. The top three signs of SBO in order, adhesions, bulge, and the cancer. Then causes, these are the causes. Starting with IV fluid, NG, Foley's, okay, as we already do in the emergency, okay. Then NG is basically help with the gastric decompression, like especially decrease the nausea, distension, and risk from vomiting. Then NP, so that's what you have to do. The most important thing, like start stopping the meal if partial SPO, then conservative treatment. So we recently saw a case where he was having pain and there was no bowel sounds and everything. Then we just keep that patient for I think 2 days with us, like one night, and it was 2 days. So usually he passed the flat test and he was discharged. So it does not mean that we have to do anything. He was not even willing to get any fluids at all, so we did not give him any fluids. Although in this case, we are going to give the conservative management with the fluid resuscitation and NG tube decompression. NG tube decompression is important. If the patient is unwilling, then we can just ask him to wait here. 48 hours after watchful waiting, if no improve or develops complications, then go for surgery. For Crohn disease, then consider the GI consult. Like in cases like patient who have already underlying pathology going on, like Crohn disease, ulcerative colitis, celiac disease, and stuff like that. In those cases, we do call GI right away. Even though we are waiting, because we need a gastroenterologist point of view to how we are going to deal with that one. Concern for the steroid management. If no clinical signs of the ischemia, short course of the conservative treatment with the fluid resuscitation, then NG tube decompression, usually they pass the flatus by that time, and duration of the observation is basically from few hours to a few days. If SBO fails to resolve, or if the patient develops some symptoms of ischemia develop, then basically surgery. So it's basically from 24 hour to 72 hours case. So up to 3 days. In books, it's written up to 48 hours of watchful waiting, because the patient, when presented for one good day, we just do the CT scan, X-rays, and all that. So one day is already been passed until we make the diagnosis. Although it's very weird, but that's how it works. In high cases of ischemia based on the clinical features, urgent surgery to prevent is irreversible ischemia. I'm just saying the cases we are going to do the surgery right away where the patient is having like complications, too much pain, unbearable. In those cases, we do everything right away. Early post-operative SBO if the bowel functions does not return within 3 to 5 days after surgery. So usually partial, extended conservative treatment 2 to 3 weeks with the bowel rest, fluids, and TPN. Now they says you did the surgery, still did not resolve. In that cases, we still with continuing with the conservative therapy for 2 to 3 weeks. Immediate surgery if ischemia, necrosis, and perforation, like having too much pain, tachycardia, fever, and you did everything and you find out that there is something going on, and then you can always do the surgery right away. These are the clinical signs: fever, leukocytosis, tachycardia, worsening pain, metabolic lactic acidosis, tachypnea. So it's important in cases of NAC-OSCE too. So please keep that in your mind. Then prevention, open surgical for has fourfold increase in the risk of SBO in the 5 years. Paralytic ileus, that could also be presenting as an abdominal pain and no passing of the flatus. So as they say, passing gas is one of the most useful indicator. Bowel sounds are diminished or absent. Okay, so in this case, as you see, we were discussing a little bit here. They says about the bowel sounds. Talking about bowel sounds here. So where this says hyperactive preceding to minimal bowel sounds. The words are different. Here this says the vowel sounds are diminished or absent. Okay, so the words are different in contrast to initial hyperactive vowel sounds in SBO. Okay, pain is often diffuse and less frequent as the colicky pattern present in the mechanical obstruction. So passing gas is one of the most useful indicator. In this case, is basically not same as the that one. It's mainly the history of some sort of medicine going on. Okay, so paralytic ileus usually present with medication. Okay, although there is many other things like abdominal perforation, infection, inflammation, that could be one of the thing too. But mainly the patient presents with either with the medication or with the electrolyte abnormalities. Okay, so these are the very important ones, like especially the medication part, like opioids, anesthesia, or any painkillers they are taking for too long that can cause it. Okay. Then investigation, same routine post-operative ileus expected, not investigation needed. So usually if it's a post-operative one, we don't do anything, no investigation. So you need to be very careful where the answer is no investigation. In those cases, people do messed up a lot. If ileus persist or occur without the abdominal surgery, in those cases we go for electrolytes, asking for patients' medications. As I said, these are the very important ones, two very common causes in Canada. Then creatinine burn, especially people who have kidney disease going on, LFT, CT scan, those ones. Then ruling out what are the underlying cause, NPO, NG decompression, fluid resuscitation. Fluid resuscitation is one of the very common because dehydration is in Canada. Then intestinal ischemia. Intestinal ischemia is basically, you can see as it can present in acute cases. Acute cases are more common as compared to the chronic cases. There is chronic cases too. In chronic cases, they present in family medicine practice with the fear of eating, having pain after that, or weight loss in those cases. But in acute, usually present in emergency. So in acute cases, vomiting, bloody diarrhea, hypotension, shock, sepsis, you feel like some sort of, bloody thing going on, like related to blood. Then there's an occlusion in the vessel, so it acute is very very painful, vomiting, and like blood. There is blood in the diarrhea, and like symptoms of dehydration, hypotension, shock, sepsis. These are the main common symptoms, along with the pain. So then we are going to start with the leukocytosis, finding out obviously CBC, doing that one. Then lactic acidosis, late finding. Amylase, lactate, CK, ALP, why CK, ALP, we want to rule out if this is related to the gallbladder or anything else like that too. Can be used to observe the progress. And then hypercoagulability, then x-ray, you are going to do the x-ray. CT scan, CT angiography is the gold standard for the acute arterial ischemia. Although in our daily practice, we don't do CT angiography. It's a very family medicine thing. In emergency, we don't do it. But if they ask for one gold standard, now I think we got the word here. These are the words that they would like to ask you in the scenarios. Like, do you know the gold standard things for whatever the diagnosis is? So, although to make the diagnosis, the thing is different, but to gold standard is different. Then is basically acute and comes with a metabolic acidosis, is basically bowel ischemia. Then starting with the fluid resuscitation, stabilizing the patient, NPO, NG decompression, and then antibiotics starting, and then we call for the surgeon to do the laparotomy. Okay, so this one here, then tumors of the small intestine is basically the obstruction that is basically presented. Short gut syndrome is also same something I saw in one of the MCC practice test. There was one of the MCQs there, so you can read their treatment. Like it's mainly the treatment is IV fluid, and in the surgery we go for like surgery right away. That's a surgeon thing. But in our case, up to our level, we go for IV fluid and TPN, and then histamine 2 anti-mobility agent, and all this we give that. Then comes to the abdominal hernia. We already saw the abdominal hernia. So femoral hernia, inguinal hernia. Uh, it's basically the two treatment and how does they present. They don't go for anatomy, that much anatomy, crazy anatomy, okay? So the complications are important because there is people in Canada, there is a lot of complications with hernia as well. And the treatment is the same, herniorrhaphy, herniotomy or something like that. So in that case, that's about it. And please do look for this picture as well. Okay. Although it's very unlikely they give you something like that, but they can give you and then ask you what kind of hernia is it. Okay. Then comes appendicitis. In appendicitis, one of the very important question or very most famous question is basically when a patient says, I don't want to go for appendectomy, how you're going to approach that case. Although we know everything about appendicitis, we have been reading out for so long, so you can read everything about appendicitis. But what you need to know is basically like those signs, and what are the points and signs where you are going to see the appendix. um, okay, then those ones, the McBurney sign, Rovising sign, rebound tenderness, Swas sign, obturator sign, those are the main important signs. And then complications, perforation, abscess, and then sepsis. And then the question I said right away, like you can start with the leukocytosis and then beta HCG to rule out for ectopic pregnancy, urine analysis, and then ultrasound, which is basically not done. The ultrasound is not very common, then go for CT scan. It's the CT scan that's we usually do that here. So if you come to the treatment, the main important here is treatment. Okay, hydrate the patient, electrolytes, appendectomy is the gold standard, complications and all that. Then consider treatment with the post-operative antibiotic for the patients who present with an abscess. Okay, palpable or the signs often delayed diagnosis with the symptoms. Consider radiological drainage or antibiotics, appendectomy once inflammation has resolved. Medical treatment. Why the medical treatment? Because in the patient who does not want to do the treatment through surgery, although it's very uncommon, but there is people like that, and they do like to ask you how you're going to approach. So in that cases, we do the conservative treatment. Antibiotics should be reserved for those who are unlit or refuse surgery. Okay, although it's a very small line, but it is asked in questions. Colonoscopy in those more than 50 to rule out the concurrent, like any neoplasm and stuff. Then IBD and all that cases. So I would suggest IBD is basically like, the complications like upper GI bleed or having some sort of constipation that can present in an emergency medicine. Itself, Crohn disease or ulcerative is not going to present. The sign and symptoms can present, and then you have to approach the sign and symptoms, because the Crohn disease and ulcerative is not a treat or is not treated in emergency medicine practice. It's a family medicine case, and even in family medicine case, our level is only make the diagnosis if possible. It does not have 100% us as a family physician to make the diagnosis. Sometimes we do test and there isn't anything. But later on, when we send to the gastroenterologist, they do make up, oh, he has whatever, celiac disease. Even recently, we were thinking of one person has celiac disease. We were doing all the testing and it was negative. Then we refer to gastroenterologist. Okay. So even the Crohn disease and ulcerative, you don't need to do a lot of it, but it's best if you can read a little bit about their first line management, because in family medicine, we do start the treatment, because until we follow up with gastroenterologist, it's going to take 2 3 4 5 months. So we do start the treatment. So it's best if you know the first line treatment. Okay. And how the Crohn and ulcerative presents. Then comes to the large bowel obstruction. We did the small one. Large one is kind of similar, but the etiology is kind of different. So just look for the etiologies. Then it's basically investigation, the same BGN, creatinine, CEA, doing for abdominal and chest X-ray, starting with IV fluids, gastric decompression, gastrointestinal decompression, then surgical intervention, the volvulus, and those ones are going to be done by gastroenterologist. Okay. This one is important, functional large bowel obstruction more than this one. This large bowel obstruction mechanical, the functional one is more important because a lot of patients present with this one. Acute pseudo obstruction. Now, in this case, distension of the colon without the mechanical obstruction in the distal colon. Then, clinical features is basically abdominal dysfunction, nausea, vomiting, pain, constipation, diarrhea. Then, watch out for fever, like signs of complication, like any signs of infection. Then you go for abdominal X-ray, the cecal dilation, treat underlying cause, whatever it is, NPNG, okay, NPONG, decompression, the rectal tube, because you have to do the rectal tube. NG is important to prevent from having nausea, vomiting, aspiration, and stuff like that. But at the same time, the rectal tube is the one who's going to help with the decompression. Colonoscopy, neostigmine, and then surgery is basically the one that's going to be done. Diverticulitis, you need to see the X-ray, not X-ray. I think it's the colonoscopy. Yeah, colonoscopy picture, if possible, from Google. How does the diverticulosis look like? And then when it gets infected, the diverticulitis. Usually in emergency medicine, the diverticulitis present with a lot of pain and then bloody diarrhea. So that's why you need to know, because this is a differential diagnosis of bloody diarrhea as well as the pain. So this one also presents with that one, and then complication is abscess, fistula, obstruction, perforation. We do CT scan as the test of choice. Okay. So although in the CT scan, I don't think so you will be able to see anything, but if you can see the cross section of the CT scan anywhere, that will helpful. Okay, very useful for the assessment of the severity, increase the soft tissue density, and 10% diverticulitis, then X-ray and then colonoscopy. Main important is asking for in diverticulitis, like a patient with constipation, history of a long-term constipation, 50-year-old, history of long-term complication, now presented with abdominal pain, signs of infection like fever, leukocytosis, bloody stool is there, right? And then you are ended up finding out that this is diverticulitis. So they will ask you what is the investigation of the choice or what is the test of choice for that one. So CT scan. Although in this case, it is basically dealt with the emergency practice. So outpatient is very, very less likely. Usually they come to family physician as a follow-up. Oh, I just went to hospital 2 3 days ago and I was diagnosed with the diverticulitis. What should I do to prevent in the future? So avoiding constipation, these ones. Conservative management, outpatient clear fluids only until improvement, avoid the treatment with antibiotics, hospitalize if severe presentation. Then CT scan is basically the percutaneous drainage of the abscess if there's a long one. Okay, then go for the surgery and all that. So in family medicine, counseling about constipation, in emergency medicine, giving them clear fluids, holding them until the symptoms resolve, and then discharging the patient. Uh, then here in the this colorectal polyp, the colon screening is important. Even in this one, the screening is important. The colorectal carcinoma screening is important. Then comes to the valvulus. Here is also one of the things that they will like to ask about this one. The coffee bean signs, omega sign, this one. Okay. So go for X-rays because it's mainly the management is the surgery anyway, and that's not our thing. Toxic megacolon. I saw one of the question in MCC objective from toxic megacolon 2, where the diagnosis was toxic megacolon and they were asking for the investigation and then the treatment as well. Then the IBD, infectious colitis. Clinical is basically infectious colitis is one of the main presentations, usually present for more than 1 week before the colonic dilation. So diarrhea, plus minus, it could be with the blood or it could be no blood. Abdominal distension, tenderness, hypokalemia, constipating agents, all of these ones we already discussed. These are the main triggers for the obstruction. Then maybe have a colitis or any other diagnosis, radiological finding out then CBC, ESR, and then AXR, like abdominal X-ray. CT scan useful to help underlying disease, but not very helpful for the diagnosis. NPO, NG tube for the decompression, stop constipating agents. And what are those constipating agents? Like medicine and then electrolyte correction, basically hypokalemia. Serial abdominal X-rays, keep on repeating it. That's what they like to ask. Like, what are the investigation that you would like to do and how often you would like to repeat it? So, not just X-rays, serial X-rays, like because we're going to keep on doing it. Then broad spectrum antibiotics, successive disease, and then we are going to look for whatever the disease is. Hemorrhoids and anal fissure. Very, very important. Don't miss this one. Anal fissures and hemorrhoids, it's common presentation. Like very important is risk factors like increased intra-abdominal pressure, constipation, pregnancy, obesity, hypertension, heavy lifting. Internal hemorrhoids, external hemorrhoids, mainly their treatment. Bleed but do not prolapse through the anus. Usually with the, it's mainly a case of like hemorrhoids is mainly a case of family medicine, but can be present in emergency as well, like patient who's having bleeding and not stopping and all that. So in this case it's mainly dealt in family medicine, not in emergency. Even it goes to emergency, they usually discharge them and ask them to follow up with your family medicine. So bleed but do not prolapse through the anus. Then high fiber diet, sitz bath, steroid, paroxamine, phlebotomics, and then ligation. That's very less likely. We go for high fiber diet, sitz bath, steroid cream, and mainly the constipation controlling and all that. If it's not resolving, then referring to the GI specialist and they will do everything. But in question wise, you need to know what are the thing. You can even do the sclerotherapy, photocoagulation, rubber band ligation. In the second case, prolapse with the straining and spontaneous reduction. So it comes out, but it goes back. Then in that cases, although constipation, sits bath, steroid, you as a family physician gonna say that for sure. But referring to a gastroenterologist, they are going to do the band ligation and photocoagulation. So in basis of the history, you will make the thing that if it's a second one and then you have to refer. Third one, prolapse and require a manual reduction. So in this case, is basically same like second and maybe needs a closed hemorrhoidectomy. Fourth one, prolapse and cannot be reduced or manually reduced. So closed hemorrhoidectomy. External hemorrhoid is basically dilate venules and usually might be asymptomatic. Pain after the bowel movement. So after pain, associated with the poor hygiene. It's mainly with the poor hygiene, dietary fibers, soft stool softeners, steroid cream, okay, proxamine, phlebotomics, and then all this one. Even I saw some of the cases where do give tacrolimus cream too. I'm not sure why, but that also helps. Thrombosed hemorrhoids are very painful. So it's basically the pain. It's perianal skin tag is there, removal within 2 days, and then treatment is basically surgical decompression. You can ask the patient to do hot compressions at home, all of that. but main treatment is surgical decompression. Indication for the referral of the endoscopic evaluation, history of melena, post-vital abnormalities, constitutional symptoms suggestive of malignancy, and then familial inherited colorectal carcinoma. So prevention, this is important. They do like to ask, how are you going to prevent it? So constipation, don't forget constipation. You have to ask them to take the like avoid constipation, fiber diet, stool softener, and stuff like that. Internal and external, painless, and this one is swear perianal pain, fullness of discomfort, perianal mass, and then mucus discharge. Anal fissure is one of the important. Usually, what happens is after the episode of the constipation and prolonged constipation going on, and now he's having pain. So, in this case, the main is basically the clinical features, very painful with a bright red blood. Okay, so don't mix up this one. This one is very very bright red blood. Treatment is conservative like stool softener, bulking agent, sitz bath, steroid cream, and all that. Chronic is basically the having pain for too long, and now patient is not presenting as if it's going on for like very acute pain. Sanitary skin tags are there, stool softeners to increase the diet, sitz bath, the nitroglycerin cream. So in this one, we are giving nitroglycerin cream and the calcium blocker cream. Okay, to decrease the blood flow, because the in this one the bleeding is going to be going on even on the tissue paper there is bleeding. It's a painful and it's keep on going on for too long. In hemorrhoids, bleeding comes only when the constipation is there. Internal anal sphincterectomy so relieves the spasm, and even in this case, we ask them to do warm compression, that can also cold compression, whatever is helpful. Then botulinum toxin as well. So avoid diarrhea and constipation, avoid straining during defecation, high fiber diet, and adequate fluids. Okay. In this case, we're asking for the diarrhea as well. So abscess is also the same. Mm, Then rectal prolapse is also kind of similar, and it's also a case of gastrointestinal. So you don't need to know a lot of this. More than liver abscess, I would suggest if you can do cholecystitis, the gallbladder abscess, pancreatitis. We will do when we do the gastroenterology. Okay. Yeah, here is the one. Cholelithiasis, you can risk factors. You can read the risk factors, obesity, age, female. So because it's a case of family medicine, that's why we are doing it. Estrogen, impaired gallbladder, weight loss, cirrhosis, hemolysis, biliary stasis, and this one. Then the most important is their investigation. What is the investigation of choice? Ultrasound is the diagnostic procedure of the choice. Okay. Then CBC electrolytes, lipase, amylase, LFTs, whatever it is. Then comes the biliary colic, that's also the painful, and then giving the analgesics and rehydration. Then comes to the acute cholecystitis. Acute cholecystitis is basically we are going to check for what are the investigations that you would like to do, what are the signs, the Murphy sign, palpable, and then tender gallbladder, swear constant more than 6 hours, epigastric. So it can present in the emergency, it can present in the family medicine both ways. Okay, so ultrasound is 98% sensitive. Consider HIDA scan if ultrasound is negative. Then signs are gallbladder thickening, edema, sludge, cholelithiasis, cholecystitic fluid, and then Murphy sign. Then complication is gangrenous perforation, Mireille's emphyema, emphysematous cholecystitis, and then cholecystoenteric fistula. So they could be a fistula formation. How are you going to treat? If it's an emergency case, admit, hydrate, NPO, NG tube, antibiotics, and if needed for ERCP. In family medicine, do all the investigation, then send to the emergency. Okay. Biliary colic is treated with analgesics and elective cholecystectomy. Acute cholecystitis is treated with antibiotics and early cholecystectomy if surgical risk appropriate. Then critical view of the safety, decreased risk of injury to the CBD. So these are the one. Acalculus cholecystitis, same thing, NPO, IV fluid, and you're going to do the ultrasound to find out the sludge in the gallbladder. Choledocholithiasis, in this case, we go for the LFTs, AST, ALT as well early in the disease. So it's important. Although we go for something else too, but the main important is basically doing for the ALT, AST, and it's mainly high. Increase the bilirubin, more sensitive ALP, GGT later on. But when we are ordering it, we don't like wait for one thing and then go for second thing. But in this one, we are going to do it. So CBC is usually normal. Leukocytosis suggests for the cholangitis, like an infection going on. LFT is increased, AST, early in disease. So they can give you a diagnosis, but asking you, like, what is the investigation you would like to do, and they can give you that this is an early, it's just recently started, having pain in the right upper quadrant, acolic stool, dark urine, fluctuating, like skin color keep on turning yellow and it just get back to normal. In the morning I noticed it was yellow, now it's not, it's fine, but yesterday it wasn't like that, so you feel like it's an early something going on. So in that cases you go for LFTs. Lipase to rule out the gallstone pancreatitis, and then ultrasound, MRC, ERCP, and then percutaneous. So all of this one is going to be done by the gastroenterologist. So the cholangitis, pancreatitis, biliary stricture, biliary cirrhosis. Treatment is usually with the ERCP. Then acute cholangitis, just to know the differential diagnosis of that one, okay? So in that case, we also go for LFTs to find out the obstructive picture. So in this one, what happened is elevated ALP, GGT, conjugated bilirubin, and the possible mild increase of AST. So as you can see in that one, the AST, the DOCO one is basically AST and T was increased, but in this one, acute cholangitis, it's mainly the infection, like CBD, the common bile duct obstruction with infection. So in this case, what is going on? The ALP, GGT, bilirubin, everything is increased. So that's why when we are doing the like sending the test, we do for everything. But when you are going to write on the exam, it's just one thing. Lipase rule out the pancreatitis, ultrasound, CT, MRCP. Initial NPO, biliary decompression with ERCP. And then in addition to the biliary decompression, the underlying cause should be addressed. In the case of patient with a choledochilitis, so in that cases, so don't reoccur. Then comes to the acute pancreatitis. Why it's important? How the presentation is. Alcoholic, homeless. So always think of someone who is alcoholic. Like, I'm not saying assume, but if they says if a 40-year-old who is homeless, they don't say alcoholic. Okay, they say he's homeless and he's having acute abdominal pain. So think of acute pancreatitis. Okay. So obstruction of the pancreatic duct by large or the small obstruction in the biliary sludge, back off of the pancreatic enzymes can be, so I just read pathogenesis by chance. So you don't need to read the pathogenesis. The pain, the signs are important, may have coexistence with the cholangitis. Ranson's criteria, physical, basically tachypnea, tachycardia, that gray Turner sign and Cullen signs, and how does they present, because they can give you the presentation and asking you what is the diagnosis. And the most important is lipase. As I said, if it's a homeless and you are thinking of acute pancreatitis, come to lipase. Do it. This one is more important than doing any ultrasound and anything like that. Elevated amylase and then leukocytosis. Elevated ALT, AST suggests that there is a gallstone etiology going on. Ultrasound may suggest that multiple stones and edematous pancreas, chest X-ray, abdominal X-ray, CT scan, if so, to evaluate for the complications. So CT scan is usually to evaluate the complications and mainly done in emergency. But in family medicine, if you think there is complication, then you can just order it. It might take a lot of time. Then the Renson's criteria on the side when you're going to do the admission. If age is more than 55, white blood cells is 16,000, glucose is basically more than 11, LDH is more than 350, AST is more than 250, During initial 48 hour, is basically uh, BUN rise more than 1.8, arterial